Cool. All right. So I'm Caroline Prentice, for those, I know quite a lot of you actually, but for those that don't know me, I'm one of the ST7s and I work at Royal Berks. It's an awful lot to cram in, but I'm going to go through some early pregnancy and acute gynae, but I'm going to try and make it case-based to try. I always find it a bit more interesting if I can think about a case to apply principles to. Oh, it's not working. There we go. So I have assumed that you've got a reasonable base level knowledge of early pregnancy and acute gynae. I'm sorry if it's new to some of you, but I think to try and have it at a level where it's this is valuable for most people. I'm assuming that you generally know quite a bit about, miscarriage and ectopic. If what I'm saying doesn't make sense to you and you think I need a bit more information, I'm going to do a totally shameless plug for my website, which is www.earlypreged.com. And there's a series of lectures broken down into topics that cover early pregnancy in a lot more detail, in a very in-depth way. So they're there if you need them. I have tried to keep the cases anonymous. If you work at Royal Berks, or if you have worked there recently, it may be that you can work out who they are, but please just try to maintain confidentiality. And I know there's a lot going on in this presentation. I've crammed a lot in, but please do just interrupt me. Don't put your hand up or put it in the chat, because I find it really difficult to do both. But just stop me, interrupt me if I'm not making any sense. So I'm going to go straight into our first case. So this is a 24-year-old woman. She's in her first pregnancy at 8 weeks. She's had some cramps and some light bleeding. She comes into the early pregnancy unit. Her observations are completely normal, and she's got a positive urine pregnancy test. So she's had her first transvaginal ultrasound today. So this is the way they look. They'll look different in different places. Just ignore the rescan bit, it's slightly repurposed. So we can see here there's a gestational sac, which is visualized. It's intrauterine. The yolk sac is visualized. The embryo is visualized. There is cardiac activity present, and the CRL is 14 millimeters, so on the smaller side, but normal. So I hope you can all agree that this is a single viable intrauterine pregnancy, and it's consistent with the clinical dates. So it's appropriate for her dates, viable because the heartbeat is present. So quite often we think, oh, that's great, the viable pregnancy, that's it, they can go. It's worth just having a little slightly deeper think about it and think, well, actually, what does that mean for that couple? So they've had cramps, they've had bleeding, they've been probably worried or anxious if this is a wanted pregnancy. So if you can see a heartbeat in a 6 or 7 week pregnancy, the chance of that pregnancy continuing is about 90%. If they've got to 8 weeks with a heartbeat, the chance of that pregnancy continuing is 98%. And if they've got to 10 weeks, it's 99.4%. So these are quite reassuring statistics to tell people. It's worth noting there's been a recent trial called the PRISM trial, and it suggests that if you've got a history of previous miscarriage, that women may benefit from progesterone supplementation to reduce the chance of miscarriage and increase the chance of live birth. It's not a guideline everywhere yet. I'm currently writing our hospital guidelines, but it's worth being aware of, because you may get particularly at the moment women asking you about this because it's been in the news. And the other thing to think about is not all pregnancies are planned and not all pregnancies are wanted. So try and gauge the mood, and if they're considering a termination of pregnancy, it's really helpful to give them a copy of their scan report and details of a local service such as BPAS or whoever you have commissioned locally. And the reason is that it may be quicker for them to access that care if they have a scan report confirming an intrauterine pregnancy. Quite often for BPAS, they don't need to know if it's a viable pregnancy or not, as long as there's a sac and it's definitely intrauterine. So worth just gauging that mood and seeing if you can help them access termination care if that's what they need. So case 2, a 24-year-old woman in her first pregnancy at 6 weeks. She's got cramps and light bleeding with normal observations. Her urine pregnancy test is positive, and she's having her first transvaginal ultrasound today. So this is a picture. This is a transvaginal scan. You can see that because of the sort of almost circular part of the probe here, and that would be much more sort of flattened in an abdominal scan. So you can see here, this is the intrauterine gestation sac. There's a decidual reaction, and that's what is meant by this whiter area around the endometrium where it's reacting to the implantation. So there's decidual reaction. You can see the yolk sac is present, so that is the sac within a sac. There's an embryo present, and it's just this little kind of blob here next to the yolk sac is the embryo. The CRL is just 3 millimeters, and that's less than the first centile. So can anyone give a stab at what would the diagnosis be from that scan? Just shout out.
Intrauterine pregnancy and viability.
Perfect. So it's definitely intrauterine because we can see the sac. We're just not sure about the viability. Although it's not looking great, it's a lot smaller than it should be, and we can't see a heartbeat. It's not enough to call it a miscarriage. So to make that ultrasound diagnosis of miscarriage, we are basing our criteria on transvaginal scanning because it provides a much greater level of detail. So if on your first scan, you've got a mean sac diameter of more than 25 millimeters and there's nothing inside it, no fetal pole, no yolk sac, then you can call that a miscarriage on the first scan. If you've done a transvaginal scan and the CRL, the crown rump length, is more than 7 millimeters and there's no fetal heart pulsation or no cardiac activity seen, then again, you can call that a miscarriage on your first scan. It's a little bit more difficult with transabdominal scanning because the quality isn't as good, you don't get the same level of detail. So if you cannot see a fetal heart on a transabdominal scan, you can either measure the CRL and then rescan in 14 days to see if there's been any change or any progress. Or if you're much more advanced, if it's, a 10-week pregnancy, it's a lot more obvious, then just consider a second opinion. So asking somebody else to come in and confirm your findings. So the reason is we're trying to minimize the risk of harming a potentially viable pregnancy. So that's why these criteria are there. And if you don't meet these criteria, then it's an intrauterine pregnancy of uncertain viability, or IUPUV, and we should be offering a rescan in 7 to 14 days. If you can see a fetal pole that's 6 millimeters, rescanning in 7 days would be fine. If you're just seeing a gestation sac, giving it 2 weeks, it gives you a greater chance of getting your diagnosis on the next scan without needing a third scan.
Caroline, can I ask a question?
Yep.
I've just wondered where those figures come from.
These are NICE. They're from the NICE guideline on management of miscarriage. Do you mean the 25 millimeters, 7 millimeters?
Yeah.
Yeah. So they're from really large case series that basically followed up miscarriages and determined a safe threshold and safe cutoff. And these thresholds have changed as ultrasound technologies got better. So it used to be a lot more than 7. I think it used to be 12 millimeters. That you would call it, but now actually with increasing advances in ultrasound, we can call it at 7 millimeters. But they're from large case series. The references for those are on the NICE guideline if you wanted to check. Now, other hospitals may not adhere to the NICE guidelines, and that's up to them to make their own pathways. And some people, it's reasonable to always offer a second opinion as well, in the spirit of doing no harm and reassuring that woman that we've got the diagnosis correct. So on your rescan, if you're not seeing any growth in the sac and there's still no fetal heart after a week to 2 weeks, then you can call it a miscarriage, because early pregnancy, it develops very quickly. You get big changes in a few weeks. So you should be seeing onwards growth in a viable pregnancy. So these are ultrasound features that you may see. They're not diagnostic, but they are prognostic. So it's not enough to say, oh, that's going to be a miscarriage, but you may sort of tone down your counselling. So this is actually the first scan that I showed you. And you can see that this yolk sac's really big. It's almost the same size as the gestation sac. So this enlarged yolk sac is a poor prognostic sign. If the pregnancy is significantly earlier or smaller than you're expecting, so they should be 10 weeks and you've got a sort of a 6-week sac with nothing in it, again, it's kind of warning you that this may be more likely to be miscarriage. But again, they could just have their dates wrong, so we offer a rescan. Other things you see is an irregular sac outline. So can you see here, this has got an enlarged yolk sac again. The fetal pole doesn't look quite right. And then you've got this collapsing irregular sac here. And this is probably a hematoma developing underneath. And here is another hematoma next to the sac. Now, again, some people will have a hematoma and go on to have a viable pregnancy. So it's prognostic, but not diagnostic. And if you can see a sac low down in the cavity or low in the cervix, it could be that this is a sort of miscarriage in progress. But again, if you haven't seen a viable pregnancy before, you can't make that diagnosis. I'm not going to focus too much on communication because it's quite hard to sort of, you need to observe it and you need to learn from others. But there is this really excellent resource from the Miscarriage Association, and it's something that we've actually put into our induction pack for our junior doctors. So the QR code there will take you straight there. It's not big, it's a couple of modules that you can do, but it's I found it really beneficial, really changed how the terminology that I use. So I'd strongly encourage you to have a look at that. So case 3. We've now got a 35-year-old woman. She's fit and well, has had one previous child, which was an uncomplicated pregnancy and delivery, which makes her Gravida 2 Para 1. She's just above 5 weeks and has come to the early pregnancy unit with bleeding that she's describing as being like a period. She does have some pain. She's got cramps, a little bit more in the right iliac fossa, and those cramps are happening with the bleeding that she's experiencing. So she has a transvaginal ultrasound. There's no gestation sac seen in the uterus. The ovaries look normal and there's no free fluid. So the summary given is a pregnancy of unknown location. And you can see here in the uterus, you've got that uninterrupted midline, that endometrial echo here with no pregnancy within. So the beta HCG is 792. And progesterone's 39. We repeat the beta HCG 48 hours later, as per the PUL protocol in our hospital, and it's dropped. It dropped more than 50%, down to 360. So what's your impression at this point?
The thing that's confusing me is why the progesterone is so high. I think off the bat, without that, I would be like, oh, it's a miscarriage, but I guess...
Yeah, so the impression given at the time and the way she was managed was miscarriage and to repeat her urine beta HCG in 2 weeks to ensure it's negative. But I've also highlighted this progesterone. That's a bit odd, isn't it? That's pretty suspicious. So progesterone, again, it's not in all the guidelines. It's not supported by NICE, so you won't see it in the NICE guidelines, but lots of hospitals are using it and testing it. So it's worth just finding out how your local unit deals with it and what they do. But that is certainly a bit of a red flag at this stage. That's quite a high progesterone for somebody that's having a miscarriage, or you think it's having a miscarriage at that gestation. But it's not unreasonable. If she's feeling well, she's not in severe pain, repeating a urine beta HCG in 2 weeks was consistent with our guidelines. So 2 weeks later, she phoned saying, I've still got a positive pregnancy test. She said she's still having bleeding and she's got a twinge in the right iliac fossa. So she's appropriately brought in, has an ultrasound, and actually there's a mass. So there's a 49 by 23 by 28 millimeter mass next to the right ovary, which is a suspected ectopic pregnancy. There's also echogenic free fluid, and that suggests that there's hemoperitoneum. But interestingly, the beta HCG has actually gone up again. So it was 2 weeks ago was 360 and is now 389, but the progesterone has dropped and is 10. So this is a real life case. It's unusual for the beta HCG to go back up again. I think we probably had a little bit of warning. She did have right iliac fossa pain when she first came to us. She did have that suspicious progesterone. So perhaps not completely unpredictable, but certainly one that could catch you out. And this was the ectopic pregnancy seen at surgery. So it's pretty large by this point. And you can see after it's been removed, you've got this sort of bluish bulge area here, which is probably the trophoblastic tissue, and then the rest of the tube just really swollen, and then the blood coming out the end there after it's been removed. So a decent size ectopic pregnancy, and that's probably been growing for the last 2 weeks since we discharged her to have a urine pregnancy test, because it wasn't seen on her initial scan. So we have a PUL flowchart. At most hospitals will have something similar. So you can see here, you've got your positive urine pregnancy test, your scan is showing you a PUL. It's worth noting that it's only a PUL depending on the competency of your scanning. So if you've got a sort of inexperienced sonographer or somebody that's not looked particularly hard, it may just be that there is an ectopic and we just haven't seen it. So always worth bearing in mind with a PUL. So she's had her beta-HCG and progesterone. The beta-HCG had fallen by more than 50%, just. So it was likely that this was a failing pregnancy, and she was discharged to have a urine pregnancy test within 2 weeks. It wasn't negative, so we didn't discharge it. It was positive, so she came back in less than 24 hours. When you've got these sort of static, difficult ones that are somewhere in the middle, if they're absolutely fine, it's probably reasonable to repeat another beta-HCG and just see if you're then developing a trend, see what's going on. If you've done 3 levels and you've not got a clear pattern, I would suggest in our guideline we should be rescanning people with an experienced sonographer. Is this an ectopic? Did we just not see it on that first scan? Should we get another opinion? You may find an ectopic pregnancy. It may just be one of these tricky persisting PULs, and you could consider either medical or expectant management depending on that trend. If you've got a rising beta-HCG that is doubling, it's probably an intrauterine pregnancy. So you could do a repeat scan in 7 to 14 days, but we should really be doing that earlier if we've got a much higher beta-HCG level. And the reason is you can have an ectopic with a doubling beta-HCG, especially if it's a viable ectopic with a heartbeat. So if you're not seeing an intrauterine pregnancy with high levels of beta-HCG that are doubling, I would suggest an immediate senior review, because this could be a really high risk ectopic pregnancy. And it's worth bearing in mind that all of this management is for people without significant ongoing pain. And if you've got a PUL and someone has pain, that's an ectopic until you've proven it isn't. So that's why we would suggest discussion with a consultant and thinking about a diagnostic lab. So beta-HCGs are really tricky. There's no single way to characterise the beta-HCG changes for an ectopic pregnancy. About 15 to 20% will have good going rising beta-HCGs, and that probably represents the higher risk ones because there's got growing tissue, they're growing quickly. 10% will behave like a failing intrauterine pregnancy, like it did in this case, that falling beta-HCG. And if you look at all of the ectopics that were misclassified initially, 80% have had that increasing beta-HCG consistent with a viable pregnancy, and that's because these are the higher risk ones. And only 20% of misclassified ectopics have had that decline like we saw. So we were dealing in this case with an uncommon situation, but you can see how that urine beta-HCG is your safety net, your backstop. So the progesterone, it's difficult. It's not recommended for NICE. Not everywhere has access to them, so that's, I think, probably one of the reasons. And they're also a little bit wiffly-woffly. So what we would generally say is if the progesterone is less than 10, it's unlikely that they need an intervention. It doesn't tell you anything about where this pregnancy is, but if it's less than 10, it's probably a failing pregnancy, be that a failing tubal pregnancy or a failing intrauterine pregnancy. If it's more than 25%, it's likely to predict a viable pregnancy. And if it's more than 60, it's strongly associated with a viable pregnancy. But again, that could be a viable, cornual pregnancy, a tubal pregnancy, something that definitely needs management. It just suggests that something is growing somewhere rather than failing. So how not to get caught out is listen to the patient. If they're saying they've got pain or they've got, funny, something in my shoulders bothering me, or I've got diarrhea, or I've got, rectal pain, listen to them. They may have really subtle signs of peritonism, indicating bleeding internally. Have a really high index of suspicion. So think about all PUL as, could this be an ectopic pregnancy? What's supporting that and what's not supporting that? Just be aware of these live ectopics. They are the highest risk, and they're also the most likely to have those increasing beta-HCG levels. And don't be afraid to get a second opinion. Get somebody else to scan, get an experienced sonographer to have another look. Think about your beta-HCG and progesterone. They're aiding your diagnosis. They're not making your diagnosis. So just because it's falling and falling well doesn't mean it's definitely a miscarriage. And then thinking about careful safety netting. So what are the signs of an ectopic pregnancy to warn that patient to look out for? When should they be seeking help? Where should they be seeking help? Have they got a number? Have you got a number they can call? Should they be going to A&E? And thinking about that urine pregnancy test. So if you have determined that a pregnancy has resolved, be that a PUL or miscarriage, having that urinary pregnancy test in 2 to 3 weeks is to help you pick up molar, to help you pick up missed tubal pregnancies. So it's worth just reiterating that, even giving them a pregnancy test to take away, and then giving them a number to call if they need it. So case 5, we've got a 34-year-old. She's fit and well. She's presented with right iliac fossa pain with no bleeding. Her initial ultrasound has demonstrated a PUL. So she's got a beta HCG of 719 and a progesterone of 58. That's repeated 48 hours later, and it's 761. So that's a suboptimal rise. She doesn't have any symptoms. Pain is not severe. She's not bleeding. So the decision is taken to go for a third beta HCG, which is in line with our guidance, and that's 844. So this is, I'm sure you'll all agree, this is pretty suspicious now for an ectopic pregnancy. So it's a PUL on scan. They haven't seen an intrauterine pregnancy. You've got quite a high progesterone there. That's approaching 60. You've got a beta HCG that is slowly rising. And so something is still going on. Something is still growing. So she's offered medical management for a PUL. This is something that you can consider. It's usually advised at consultant discretion only, but it was felt that with those rising beta HCGs, with the situation, it's probably an ectopic that we hadn't seen. So offering medical management with methotrexate was reasonable. This was accepted by the patient, and so she came in for another blood test for her baseline bloods and a rescan. Interestingly, on the rescan, actually, they found the ectopic. So it, sounding very much like an ectopic. She had a little bit of pain. The bloods were following that trend. And this is a small ectopic. So it's on the right side, 21 millimeters by 17 by 18. You can see there it's a classic sort of what we call a bagel donut. So you imagine it as a cross section of the tube, and then that's the gestation sac within the middle. With an eye of faith, there may be a developing yolk sac there, but certainly quite a classic and obvious ectopic pregnancy. Her beta HCG is still increasing at this point, so it's 1,174. So she meets the criteria. She doesn't have any medical reasons not to give her methotrexate. She accepts that medical management, and she started on the protocol. So with methotrexate, we do beta HCG tracking. So she's had her day 1, her day 3, day 7, and these are all actually decreasing acceptably. So it's interesting that even her next beta HCG is still going up. She's still getting a good going rise, but once the methotrexate's given, we're starting to see everything fall down, and these are all within the acceptable decreases. So she's coming for weekly beta HCGs now and a telephone call follow-up. On day 21, she has this beta HCG of 507, but on her telephone consultation, she's actually reporting pain. So she has a new onset pain, is brought in for a scan. This shows a 54 by 24 by 54 millimeter right-sided mass. She's got free fluid and low level echoes. So that's the scan. So you can see here, this is the mass. So this is the uterus here. This is the mass that they're looking at. And this here is the free fluid. And the reason I've included this picture is this is what we call echogenic free fluid. So it looks grey. It doesn't just look like, if it was the bladder, it would look plain black. But this is thickened fluid consistent with blood in this case. So we're basically saying she's got pain, the mass has got bigger, and now she's got signs of intra-abdominal bleeding. So the only option for her, unfortunately, is for surgical treatment. And you can see here, this was enormous by this stage. So this is a really large ectopic. You can see a little bit of normal tube just coming here, and then this grossly dilated tube here, and there's blood everywhere. So blood coating uterus, blood coating the bowel, and it's pooling in the pouch of Douglas. And that's exactly what you're seeing here. You've got blood here, blood here, blood here. And that's reflected with her surgical images. So she underwent a salpingectomy. So this is the ectopic flowchart that we have. So once you've diagnosed an ectopic pregnancy, you have to think about how can we manage this. Now, hopefully we're diagnosing these on scan because we've got, high quality sonographer skills. So if somebody has severe pain or hemodynamic compromise, there isn't really an option. It's pretty obvious they need surgery. If they've got hemoperitoneum, now I've specifically said hemoperitoneum, not free fluid, because free fluid can be a normal finding for many women. So if we're suspecting hemoperitoneum, then again, if you're already bleeding, you're pretty much resigned to surgery. If you've got a fetal heart present, so a live ectopic pregnancy, then again, they're less likely or unlikely to respond to medical management, so we should be offering surgery. And if your mass is already greater than 35 millimeters, again, surgery is the option. This one's a slightly more nuanced situation. So to have conservative or medical management, it's quite involved. It means coming for lots of blood tests, and it means having the ability and to report symptoms if you experience them, and the ability to get yourself to hospital. So if you think you've got a patient that's either not going to come to follow up or going to struggle to access follow up, setting them on a potentially a 6-week long treatment is not always the right option. But if they will attend follow up, then it's important to know the beta HCG. Now, the chances are you'll probably know that anyway. If you've got a beta HCG of less than 1,000, it would be reasonable to offer conservative management, so watching and waiting. And that would involve monitoring your beta HCG in the same way that we do for medical management. And if it's decreasing on its own, then you don't need to give them methotrexate because this pregnancy is resolving. It's likely to be a tubal miscarriage type picture. If their beta HCG is between 1,000 and 1,500, it's reasonable to offer them medical management. It's less likely, but not impossible, that conservative management will work. So you could offer them either. If the beta HCG is over 1,500 but less than 5,000, if they want surgery, that's a perfectly reasonable option, but they are also suitable for medical management with a beta HCG of up to 5,000. It's unlikely that conservative management will work. If the beta HCG is greater than 5,000, we would recommend surgery as a first-line option. But it's worth noting that there are always going to be cases that don't quite fit these criteria and that don't quite work. So you can give medical management to somebody with a beta HCG of greater than 5,000. It's just slightly higher risk and it's less likely to work. But you might be balancing that if their BMI is 60 and they've had 4 previous cesareans. Veronica, have you got your hand up? Did you want to say something?
Yes, I do. Sorry, Caroline, I just had a question in terms of if the location of the ectopic changes your management, and whether you could comment on that.
It absolutely does. These are for tubal ectopic pregnancies. So there is a really good Royal College guideline about non-tubal ectopic pregnancies. They're generally managed slightly differently depending on their location, and they're something that they're uncommon. So it's worth taking them on a case-by-case basis. There isn't a flowchart that you could use for non-tubal ectopic pregnancies, but because tubal ectopic pregnancies comprises about probably greater than 90%, that's why it's what we focus on the guidelines. But yeah, check out the Royal College guideline for specifics.
Thanks.
So things like ovarian ectopic pregnancies are quite tricky to manage, and lots of other types won't respond to methotrexate, but it's all in the guideline there. So as with anything, it's get your senior consultant, ideally with an interest in early pregnancy involved. Consider, what does the patient want? Are they suitable for methotrexate? Have they got any other medical contraindications? Think about the surgical complexity. They may want surgery as a first line option, but if it's going to be particularly high risk, it may not be the best option for them. So conservative management is essentially a wait and see approach for a carefully selected population. So they have to meet all the criteria and they have to have decreasing beta HCGs. About 30% will be successful just with watching and waiting, but it can take up to 6 weeks for that beta HCG to fall. So you flip that over, the other 70% will end up needing either surgical or medical management. So medical management is with a single dose of methotrexate. It's got quite a good success rate, about 90%, but some people do need a second dose. and surgery may be required if it doesn't work. And it's just worth bearing in mind that, as in this case, there's a 7% risk of rupture whilst they're on the treatment, and that's regardless of what their beta HCGs are doing. So it's important to let them know that that risk is there. And then part of the follow-up in doing the beta HCGs is not just looking at the trend and checking it's falling, but actually speaking to the patient. You know, has anything changed? Do you have any other symptoms? Tell me what's going on. The surgical options are either salpingectomy to remove the entire tube, or salpingotomy, which is where you open the tube and take out the ectopic pregnancy. It's usually definitive, doesn't often require follow-up, but it is about a 2 per 1,000 serious complication rate, and that complication rate will be higher for women that have a high BMI or lots of previous surgery. So it's worth bearing in mind your options depending on the patient in front of you. So if patients often say, well, what do you think? What's the best option for me? And it's worth knowing quite a bit about their history and their future fertility desires. So if they're not bothered about having another baby, if this was unplanned, they definitely don't want any more children, then you can just take the tube out. So that's quite easy. If there's no history of subfertility, there isn't actually any difference in the outcomes. So if you've got somebody who just has an ectopic, they've got no risk factors that you know of, there's no real difference with any of the treatments. If they do have a history of subfertility, if it's taken them a long time to conceive, if they know that they've got a hydrosalpinx, if they've had previous, chlamydia, PID, conservative or medical management is associated with improved outcomes for future pregnancy, which is obvious really, because they'll have potentially a damaged tube, and letting them have one damaged tube and one maybe not damaged tube is potentially better. If they've had a previous salpingectomy, so they've already had an ectopic and they've lost that tube, you should strongly consider conservative or medical management. It's tempting to offer salpingotomy. The surgery for salpingotomy is not easy. You have to carefully open the tube with electrocautery, wash out the pregnancy that's there. There's a risk of retained tissue, and sometimes they just bleed too much and you end up having to do the salpingectomy to stop the bleeding. So it's worth having it as an option, but would strongly consider conservative or medical management first. So thinking about methotrexate, which I've abbreviated here to MTX, there are some factors that are associated with successful treatment and some factors that are associated with failure of treatment. So a good candidate, an ideal candidate, would have a heterogeneous mass type ectopic rather than a gestational sac. They would have a lower starting beta HCG, and that beta HCG would be really almost static or slowly rising, and you would expect that big drop. So a nice big drop after methotrexate suggests that it's working. So contrasting that to someone who is a less ideal candidate or that has a higher risk of failure, and it's not to say that you shouldn't offer it, it's just to make them aware. If there's a gestation sac, certainly if there's a yolk sac or an embryo, obviously if there's a positive fetal heart, you're not going to offer it. If they have a higher starting beta HCG or a rapidly rising beta HCG, and actually that's what we saw in this patient, her beta HCG was really jumping up as we were monitoring and scanning and deciding. If there is a smaller drop after the methotrexate is given, or if they need a second dose, and if you get an initial increase on that day 1 to day 4, now we do see that and we accept that as part of the treatment, but if you do see that increase, it's again like a warning sign that this could be potentially a treatment that's going to fail. So thinking about prognosis and follow-up after an ectopic pregnancy, about 90% will have a successful future pregnancy if there are no other subfertility factors. And that's quite reassuring. Unfortunately, a lot of women do have subfertility factors, and that's why they've had an ectopic pregnancy. So if they have got those features, such as PID, hydrosalpinx, they've had a previous ectopic, they've had lots of abdominal surgery, the successful future pregnancy rates drop to about 60%. The recurrence rates are variable, depends on which study you look at, but they're probably somewhere between 10 and 18%, so quite high. And that's why it's vital that we offer early scans in subsequent pregnancies at around 6 weeks. So the reason we advise early is because if we can catch a small ectopic pregnancy, we may be able to more successfully manage that with methotrexate, rather than if they pitch up later on when it's too big or it's developed too far or the beta HCG levels too high. It's also important to consider psychological well-being, because it's a pregnancy loss, and I think sometimes we forget that because it's not a miscarriage, that we're just managing a medical condition. But for that couple, for that patient, it is still the loss of a pregnancy. And there's lots more information on the Ectopic Trust website, which is helpfully just called ectopic.org.uk, about dealing with thoughts and feelings surrounding pregnancy loss specific to ectopic pregnancy. So case 6, this is a 25-year-old, she's fit and well, no medical history of note, came to ED with severe lower abdominal pain, and this was really sudden, and the onset was after intercourse, and her last period was 3 weeks ago. So on initial observation, her respiratory rate was fine at 16, her blood pressure is normal, 128/78, her pulse is raised, 110. SATs are 99%, her temperature's okay. So what are you thinking at this point? So you've got this woman, if I go back, she's 25 years old, fine, otherwise no other medical history, sudden onset pain after intercourse, last period 3 weeks ago, and a pulse of 110. Just shout out any ideas.
Trauma.
Trauma, yeah.
Cyst accident?
Yeah.
Yeah, it has to be something that's acute with the onset of the pain.
Yeah, so we think it's something acute, something has happened. It's clearly she was fine enough to be, you know, at home having intercourse, no problems, and then has pitched up in A&E. So there's something acute, something unusual has happened. And she has a tachycardia, so it could be a pain response, it could be that she's anxious, or it could be a sign of something underlying that's worrying. So you get her bloods back. Her HB is 121, her white cell count is 17, her CRP is 0.6, she's not pregnant, her beta HCG is less than 0.1, and her USNEs and LFTs are normal. So there's something going on, isn't there? There's something not quite right here. Helpfully, you've got a lovely ED reg. She goes, oh, I'm going to get my fast scanner out. So they do it's a focused assessment, something trauma. I can't remember exactly. But anyway, they do a lovely scan and they can see there's some free fluid and a pelvic mass. So what are you thinking now?
Is she bleeding from a hemorrhagic cyst?
Yeah, she could be, couldn't she? That's a bit worrying. She shouldn't have lots of free fluid. And why has she got a mass, and what is that mass? So she goes off for a CT because it's the middle of the night and no one's really quite sure what's going on. So the CT is highly suggestive of hemorrhage from a ruptured ovarian cyst. And when her bloods are repeated to get a group and safe for theatre, her haemoglobin's dropped from 121 down to 106. So what are you going to do now?
Taking a theatre.
Yeah, this isn't great, is it? You've got somebody who's young, fit and well. She's dropped her HB. You've got evidence that there is something going on. You've got evidence of hemorrhage. You've got all the bits that you need. So what actually happened is that this was probably about 4 a.m. She was transferred to the ward. So she was transferred to the ward to await theatre the next day. She was kept nil by mouth, not given any fluids, and sat upstairs. Then, due to various factors and delays in the morning, she got into theatre at about 4 o'clock the next afternoon, so about 12 hours from her presentation. And this is what we found. So as soon as we put the ports in, there's clearly quite a lot of blood in this abdomen. We indeed found this large cyst. It wasn't immediately obvious that it had ruptured, but once you lifted it up to the posterior surface, you could see a rupture point, and you could see that there was active bleeding from this rupture point. But it was difficult to see because it was on the posterior surface. So she had a laparoscopic management, a washout of all that blood, and then diathermy to the bleeding edges of the cyst. It didn't stop the bleeding, so we then packed the cyst with some Surgicel, which seemed to settle everything down. And she actually lost in total, we measured it all because it was in her abdomen, 1.5 litres of blood. And this is a woman that had been sat on the ward, otherwise well, with a slight tachycardia. So post-op, her HB was 81, and that's probably more reflective. So she's dropped from 120 down to 81. And it's worth thinking about the way that we see hemoglobin changes in young, fit women with acute hemorrhage. It takes time to show a drop. So I always describe it, and it's very oversimplified, but as a teapot analogy. So if you've got strong tea in a teapot, that's like your blood. So if you pour half of that tea out and then measure it, it's still going to be just as strong. The tea that is inside the teapot, there's just a lot less of it. When you then top up that tea in the teapot back up to the normal level where it was by putting extra fluid in, and then you measure the strength of the tea, that tea is a lot weaker. So you don't always see an acute drop in hemoglobin. And if you do see an acute drop in hemoglobin, it's likely that they've bled an awful lot. So it's worth taking seriously, and that her drop from 120 down to 106 is really significant, and it's reflected by the time that we've given her some fluids, she's had her surgery and we've sorted it all out, that actually her true post-op HB was even lower at 81. Thankfully, she responded to Ferinject and iron. The advice for her was to consider the combined oral contraceptive pill as prevention. So having a Mirena doesn't stop you ovulating, having a progesterone pill doesn't generally stop you ovulating, but the combined oral contraceptive pill taken back to back will prevent most ovulations, and so will potentially reduce the risk of this happening again. It's worth noting that you should always take free fluid seriously, but it's really useful to know if that is echogenic or if it is just fluid, because it could be fluid from a ruptured cyst that's just leaked some clear fluid. So it's useful to know whether that is echogenic or not. Young women that are otherwise well will compensate, so they can use a significant amount of blood without dropping their HB. They don't faint, they don't fall over, they basically look fine until they're not fine. So you have to take it very seriously, and it's the same in obstetrics as well, but we often forget that it can happen in gynecology. So you may find that a raised respiratory rate and a raised pulse may be the only subtle signs that you have. By the time a young fit woman has dropped her blood pressure, you're in serious trouble. So don't wait for the late signs, but think about it early. Think about repeating a gas. Think about rescanning and seeing what's going on. So hemorrhagic cysts generally are common. You'll see them quite a lot. You may have pain that results from bleeding into a cyst. So it could be that they have a simple cyst that's there. They've then had, trauma from intercourse or anything else, and they've bled into that cyst, and that's painful. But it can also be, less commonly, that cyst has ruptured, and it may be that it was actually more of a corpus luteum and ruptured rather than it being a simple cyst. So ideally, we would try and manage them conservatively. The reason we want to manage them conservatively is because there's a higher risk of bleeding during surgery. So you could see that was really actively bleeding. Every time you operate on an ovary, every time you remove a cyst or treat a cyst, you're potentially damaging the ovarian reserve and affecting their future fertility options. So this was a 24-year-old lady that doesn't have any children yet, and we'd like to keep her options open. There's also a risk of oophorectomy. So if you have bleeding that you can't stop in any other way, with diathermy, with packing, with suturing, you may end up having to do an oophorectomy just to stop the bleeding, which again is potentially impacting on their future fertility. So because they're likely to resolve, it's reasonable to rescan a hemorrhagic cyst if they're not acutely unwell within 3 to 4 months, because most of them do go away. The only caveat to that is just beware if they've still got pain, if they've got other signs, you can bleed into a cyst because it's torted. So you may find that a new hemorrhagic cyst is a presentation of torsion. The other thing we need to be cautious about is if they have a bleeding disorder or if they're anticoagulated for some reason. So if you've got somebody with, von Willebrand's or a haemophilia carrier, they're less likely to just self-manage that hemorrhagic cyst. They're also much higher risks surgeries. So worth just bearing in mind, and it may be their first presentation. So simple things, asking, are your periods normally heavily? Have you ever had any teeth taken out and bleeding? Have you ever had nosebleeds that haven't stopped? And just thinking, could this be a first presentation of a bleeding disorder? It's unusual, but it's not unheard of. So we've got maybe 2 minutes. I'm sorry, that's such a whistle-stop tour. There's lots of things I know I haven't covered. So we didn't talk about molar, we haven't talked about a PID and infections and things. But I thought trying to cover the more common things would be beneficial. As I've mentioned, there's loads of stuff and lots of different talks on my website if you wanted a bit more information. But does anyone have any questions at the moment or any cases they want to talk about?
Thanks, Caroline. What's the relevance, or like not what's the relevance, but how common is there a trauma history, or like an intercourse history, particularly regarding the ruptured cysts?
Quite common. So they often talk about they were, walking or exercising or intercourse. I'm never sure if it is a true trigger or if they just think, oh, they feel a pain and think, oh, what's brought that on, and whether it's a, a false association. But it can happen spontaneously, especially if it's a corpus luteum. There won't be a trauma history because they are just meant to rupture to release that cyst. So a corpus luteum often will come with no history, but the clue for that is where they are in their cycle. If they're mid-cycle, so things like that aren't going to happen during their period or the first week of their cycle. So taking an accurate last menstrual period is important.
Cool, thanks.
Cool. So if there's no other questions, again, further shameless plug of my website. And if you could give some feedback, that's the first time I've done lots of these talks. It's the first one I've tried to do entirely case-led. So if you could scan that QR code, I'd be really, really grateful if you could give me some feedback, if it's helpful or not helpful, or any tips basically to make it more useful in the future for your future colleagues. But thank you very much for listening.